Hello, this is Mickey Yurday for Halteris Associates, and thank you for joining us for another episode of Interesting Stories in the History of Diagnostics. I'm going to be joined by a guest star today, my old friend Scott Eastman. We'll tell you more about Scott in a few minutes, but today we're going to be talking about
The science of Theranos. What went wrong?
I'm sure many of you are very familiar with them, but we're going to talk about the experiences that Scott and I have had in interaction with Theranos and their technology, and tell you a bit about scientifically why we didn't get it.
My initial interactions with Theranos came way back in 2006. And I had been approached by a friend who was at Alta Partners named Ed Hurwitz. And Ed had been approached by someone who suggested he take a look at this company as a potential investment. So Ed asked me to come along with him to do some diligence on the company. And I did. We went down for an afternoon. And I recall going in and sitting at the end of a large conference table with Ed and hearing a presentation from Elizabeth. And she told us a lot of things about what they were trying to do and what the vision was, the science and everything. And I remember thinking to myself, there's something that isn't quite making sense to me here. So I made a few calculations on the pad of paper in front of me and realized that there were some major issues that were problematic. And at the end of that, I had a conversation with Ed, and I also wrote a report for him. And my recommendation was that they not invest. And obviously they didn't. And I talk to Ed every once in a while, and we talk about the fact that they really dodged the bullet. And after we go through the science today with you, I think you'll see it wasn't a very difficult decision.
So I'd like to explain what I thought the science issue was at Theranos. But in order to do that, I need to give you a little bit of background. I went to visit Theranos in 2006. The year before that, I had started a company with a number of people called Tethys Biosciences. And what we were trying to do is detect new biomarkers in blood for a number of different diseases. The problem we had was that the amount of sample people had was very low. At the most, they might have had a milliliter. And for a lot of assays that were available at that time that you would want to use to quantitate, you'd need almost the entire sample. We wanted to find a technology, if we could find it, that permitted us to do quantification of serum proteins in very small volumes. That was the key. But to do that, you'd have to have very high sensitivity. I had been working with a company called Singulex for some time. I consulted to them for some years, and then I became a member of the board of directors. And they had a very impressive technology called single molecule counting, which literally could count single molecules one at a time in a substantial volume of sample. We had access to that. And as I'm going to show you in a few moments, it's actually about 100 to 1,000 times better than what was available at the time. At the time, the best technology out there for performing immunoassays was the ELISA assay. Been around for a long time in a lot of different forms. And the ELISA assays just didn't have the limit of detection or limit of quantitation that we needed. Okay, that's important. So with that background, I wanted to just talk a little bit about what was possible with an ELISA assay and what the people at Theranos claimed that they could do, to give you some sense for why I was surprised. So on the left-hand side is a set of human proteins, human secreted proteins found in blood. In fact, the ones I have listed here are from a list that was presented to me by Elizabeth Holmes back in 2006. They include VEGF, TNF alpha, interleukins, but it just said interleukins on the list, didn't say any specific ones. I picked one that wasn't so difficult to detect, IL-6 here, leptin, GLP-2. And the next column is the best ELISA lower limit of quantifications that were available at that time. And in fact, it's still the case for almost all of these ELISA assays, that they're in this range. And I'm giving this now in terms of picograms, PG, per milliliter. So 10 to the minus 12 grams of material, of the protein, in 1,000th of a liter. Okay, so their limits of detection were for VEGF 20, alpha TNF 11, we got 10, we got 40, all in the same range, which is, on the order of tens of picograms per mil. Now, they didn't use a whole mil for these assays. Typically, what they used in the next column is 1/10 of a milliliter, or 100 microliters. And so the number of picograms present in that sample would be 21142. So that's the actual number of picograms. Now, what was surprising to me was that the claims by Theranos were much lower than those amounts. But just to be fair, wanted to think in terms of the Singulex technology as well. And The Singulex technology was used to develop assays for some of these targets, in particular the first three. And I had opportunity to go back recently and look at that. This was from 2009. And I calculated from the number of microliters of sample that they had, how many picograms there were in each one of those samples. And I confirmed this with, in fact, the former R&D head there, John Todd, who works with us at Halteris. And so these are the numbers. It would be, for them, 0.025 for VEGF. Remember, I said it was about 100 to 1,000 times better than a standard ELISA. So that holds up. Also, for the TNF alpha, 0.018, and for interleukin IL-6, 0.006. That's how much the guys at Singulex had with the super sensitive new technology. Now, here's the thing. We didn't see any evidence for the fact that Theranos had anything beyond an ELISA technology. In fact, she told me at the time that they were looking at perhaps low picogram per mil detection. Okay? Sounds an awful lot like an ELISA, doesn't it? But what she claimed was that they're going to detect this in 0.3 microliters. 0.3 microliters. So that's 0.0003 milliliters. That's not a lot. So when I calculate the number of picograms, given those same sort of detection limits for a standard ELISA assay, I came up with 0.006, 0.003, 0.003, 0.012, etc. Note that all of those are even below the detection limit possible with that super technology from Singulex. So with an ELISA, they're orders of magnitude off. There's no way. They couldn't have done it. So did a few calculations on the back of an envelope and try to figure out what that lower limit had to be. And so that's why I came out scratching my head.
And we have a guest today, Scott Eastman. Scott and I have known each other for a long time. As a matter of fact, I've hired him now in, I think, 4 different companies, working in 6 different companies together. So we go back a long time. So he and I are going to have a conversation about the interactions we've had with Theranos. We both have had them on different occasions in different ways. So I'll turn it over to Scott now. And Scott, what were your initial interactions with Theranos that led you to the sort of thinking we're going to talk about today?
Well, my initial interactions were actually the company I was working for at the time saw what Theranos was saying that they could do, and they started pushing me we want to do that. And I kept telling them that it's not possible to do that. So they had somebody else in the company put 4 or 5 people onto this for a couple of years and couldn't reproduce it. So my initial interaction was, it's not possible to do it. It's crazy to think you can do it. And it turns out you can't do it. And so I also worked on ultrasensitive immunoassays at Crescendo Bioscience,
right?
And came to the realizations, while I'm not going to present data from there today, it falls right in with everything else that we're talking about, that you need to be able to quantitate this accurately.
Yeah. So why don't we jump into it then, Scott? Why don't you just kind of walk through what Theranos said they were going to do and what some of the issues were?
What Theranos proposed to do was to develop a finger stick assay for various different analytes, much like you would do glucose, right? They felt that they could do it on 5 microliters to 10 microliters of blood. Now, a microliter is 1/1,000,000th of a liter, which a liter you can think of as about a quart. So they felt that they could do this, and none of it had anything to do with the assays on the back end. It was all about how they get the sample.
And by the way, they told me at this meeting that they were going to go below that in the future to 0.3 to 1 microliter. So making it even more difficult.
Yes. Over the course of time, they had gotten many investors, including George Shultz, Secretary of State, to invest large amounts of money in this company. And yet most of the testing that they did was just standard ELISAs that we normally would run.
Yeah, well, that to your point, they They intended to go to as many as 1,000 assays very quickly using this very small volume approach.
For highly abundant proteins, like one of the examples I pulled out because everybody knows it is human chorionic gonadotropin, right? Very highly expressed protein in the context of pregnancy. Otherwise, it's not expressed very much at all, which is uncommon. That's more like infectious diseases. But most of the proteins that people are interested in, like cytokines and interleukins, are actually relatively low in concentrations. And there's this paper from Anderson and Anderson in Molecular and Cellular Proteomics from 2002, in which they gave an abundance of all the different proteins that to this point have been identified in plasma, which is the liquid portion of blood. These analytes cover a concentration basically from 0.1 picograms per mil to over 1 billion picograms per mil. So there's a huge range in doing this.
10 orders of magnitude. Yeah.
Orders and orders of magnitude. And the other thing to be aware of is that most all of these proteins are proteins that are normally expressed in humans. So it's not like infectious diseases. It's there or it's not. It's there, but how much of it is there?
If we look at what the standard immunoassays could do at the time with these ELISA sort of formats, they could do a significant number of those proteins down to perhaps 10 to 100 picograms per mil. Getting below that was pretty tough. And this is using as large a volume as you want to take, right, to get to that level of sensitivity. And below that was one of the reasons we were looking at some ultra-sensitive methodologies, but it really is challenging, even today, to get to below about 0.1 picograms per mil for most people. So there's some new technologies that are permitting that. It's not standard by any stretch of imagination, using large sample volumes.
When I was at Crescendo, we did IL-6, which, from what I understand, talking to most people, is considered the most sensitive IL-6 assay that's out there. We developed that, and it is a struggle for most companies to be able to actually even run that kind of assay. IL-1 beta, interleukin-1 beta, 50% of the patients, you'll never get a result. It's there, but you never get a result. You just don't have the sensitivity.
Yeah, it's unattainium, as some people would say.
Yeah, I love it. So let's do it as fishing. And we're going to toss a net out, and that net for Theranos is only 10 microliters. But that ocean is vast, right? So for HCG, human chorionic gonadotropin, and glucose, which I showed you had well abundant, lots of protein in there. Catching those fish and casting that net is a very easy thing to do. So, wow, you got a great haul. It's easy detection. Everything's great. Unfortunately, there aren't a lot of proteins that are at that level. So what you do run across is we've still got the 10 microliter net, but now when you get down to fishing for CRP or leptin or VEGF-A, these markers are much more rare. They're harder to catch, and it may require many tosses of a net that's only 10 microliters. And if we just simply increase the size of the net, we stand a much better chance of trying to pull in these low abundant proteins. Where Theranos can't get it is at these low abundant proteins. The math just does not support. You'd have to sample so many times, and that would not be an acceptable clinical assay.
There were other issues that we were concerned about too. You know, again, when we were at Tethys, we were working on a method to collect samples with finger prick blood and then to use that to quantitate a number of proteins that were much higher concentrations than these. And I remember that we had a problem because, of course, the capillary blood and the venous blood are not quite the same here. You've got problems of getting a sample that represents venous blood. So we actually had to have a normalization marker, if you will. And we're using sodium. We're using ratios of the protein to sodium because sodium is so stable in a normal, healthy person. Of course, they didn't talk about any of that sort of thing. I never did understand how they thought they were going to deal with using not only finger prick blood, but such a low volume of it besides.
Yeah.
In fact, you'd have to throw most of the finger prick blood away if you're just going to take 1 microliter, because you're going to get somewhere between 10 and 25 to 50 microliters, depending on the person, because we don't all make all that much. But there are just some practical issues there, too.
I think there's some practical issues just with collecting the sample. I mean, if you're just going to use a glass of microcapillary pipette to pick up 10 microliters, it's going to clot in that capillary pipette, and you're not going to get 10 microliters back out. Just even the mechanism on how you're going to do that is not clear, how the best way to make that work is.
Now, you're not going to do the 1,000 assays on any one person, but you often need several different assays to give the physician what it is they need here. And so how are they thinking about multiplexing? How are they thinking about how that would be done? Would you end up having to take a much larger sample than you diluted it into every one of the assays, or?
Well, it was interesting because they had that 0.3 microliters. I have for years forced people to do experiments that say you can't accurately pipette under 10 microliters. So the idea of trying to pipette reproducibly, and I don't care if it's with a robot or what, robots take a lot of effort to get them to a point to where they can even approach how reproducible a human is, and then you can get them past that. But there is no way, I don't care if it's Tecan or Hamilton or whoever, you cannot pipette.
There's some really interesting different sorts of devices to do nanoliter distribution, but they're not something you use in a standard laboratory. That's for sure.
And part of this, Mickey, is that we in science have benefited from amplification strategies, signal amplification like BDNA, target amplification with PCR and T7, and all different kinds of strategies to amplify tiny, tiny amounts of the analyte within a sample. And we are assuming that we are 100% efficient on that, which we know we're not. But you've got to have something to amplify.
It's very interesting to look back and see how many people, for whatever reason, didn't really do the calculations. It's just so surprising that such a myth could be perpetuated for so very long.
The math doesn't support it. I know a lot of companies put a lot of money into trying to do this and couldn't do it.
Well, now we've got all these microsampling devices that people are using, like Tasso and YourBio and others. That, you put it on and it painlessly draws blood. Not 1 microliter, not 1 milliliter, but a couple hundred microliters, which is pretty good for a lot of things. You think back, there were some really good scientists on the staff. Ian Gibbons, for instance, who I had met with Ed Hurwitz because they were both at the company of Clara before Ian went to Theranos. He's a really good scientist, he was. And you look at this and you say, with some very sophisticated people who went in to look at this, how was it they didn't see through this?
I think that it became such a promise that the consideration of is it really possible kind of disappeared. That's the only thing to me that makes sense is, it would be wonderful if everything could be done on a single finger stick and you knew everything about your body. Well, unfortunately, biology is not like that. But I think it's a consideration of this would be wonderful if they could really do it. But when it got right down to can you really do it, the answer is no. again, I go back to some of the higher level analytes, yeah, sure, you could do that with this finger stick technology, but it's not clear to me that that technology has any advantage over the current technologies that they're using right now. What's the advantage of a finger stick technology over venipuncture?
Yeah, well, to me, it would be being able to get the answer on site very quickly without venipuncture blood. Where would it be that you would need a fast result that would help make a decision? And you can imagine a number of situations like that. I mean, there is obviously a big push today to get more and more testing towards point of care.
Where you would
OTC.
think places like that might be useful would be the troponins, right?
Mm-hmm.
And they have that all stat in the hospital these days.
Right. And the point of care approaches may not be necessary when you've set up the system for getting the sample to the lab associated with an emergency room so fast that you get a really high quality result quickly. Yeah,
Yep.
That's the constant battle.
Yeah,
so we use a laboratory, and we use point of care. Oftentimes with point of care, like an emergency room, there's no place to put the darn thing.
Can we improve what they're doing in the clinical laboratory? Right. Is this going to improve what they're doing in the clinical laboratory? I don't think so.
I guess it's possible that some people were thinking, oh, I really do see they can't do those lower levels of concentrations, but I'm happy enough with the things they can do at high concentrations. Although, that leaves off of the list, I think, a number of things that were routine tests that means they couldn't offer, which would be a problem. But in situations where you need a fast answer for the best and quickest path to treatment, so-called test to treat, as we're hearing now from the Biden administration about SARS-CoV-2. That's only going to happen if we've got these point of care or over-the-counter tests, because otherwise you've got to send it out for a couple of days for PCR, and it comes back a few days later. And then you've got these drugs like Paxlovid that only work in the first several days. Getting the rapid results and then administration of the drug makes a difference. And it's also a matter of convenience too. If it is a home test, nobody's going to be taking venipuncture blood from themselves.
Oh, right.
And you're going to take a small sample. So what if someone else came out today and said they can do exactly what Theranos does? Would it receive a different response from people? Would people be less likely to believe it today, or would they be fooled again?
I personally think they'd be fooled again. That's my. I mean, I think there will be some.
They're going to have to hire one of us to go look at the company for them.
Yeah.
Look at the calculations.
Stand outside with my big numbers and my math and my Excel spreadsheet.
Yeah. I mean, it may not be this particular thing over again, but other situations where people are talking about things which are going to break the second law of thermodynamics or perpetual motion machines and this kind of thing. You just look at some of these and you go, guys, it can't work.
There are certain things in physics and science there are laws you just can't break.
Yeah, right. Yeah. Cold fusion.
Yeah.
I got it right here.
Yeah.
This glass of water, there's a fusion reaction right there.
Yeah.
Scott, we did have the experience we did at Tethys, where we had the access to the single molecule detection methodology from Singulex.
Mm-hmm.
And we were able to actually do things that I think people would probably still find rather surprising. For instance, we would be able to take clinical samples we got from people, and small amounts of them, and we dilute them by 100 to 10,000 fold on scale to be able to read. Now, those proteins were all in that upper range. We were really focused on having a very small volume.
I do think, Mickey, that there is going to be, I want to say, a convergence of some of this stuff, because I look at that glucose monitor I say that's a first step. This is something that people could, over time, with engineering, improve it and do a lot of assays on that and monitor a lot of things for people. It's not going to happen tomorrow. It's not going to happen for some time, right?
Well, Scott, you're not going to believe this, but just before we started this call, I had a conversation with some people who say they've already done it.
Wow, really?
I'm not kidding. What's really interesting to me is that this whole notion of continuous monitoring,
Yeah.
we're seeing things we would never have believed were possible. For instance, Emory University and Lawrence Livermore National Lab did a study on temperature fluctuations in people who were hospitalized. And they found that particular levels of fluctuation were prediction of whether someone would have significant morbidity and mortality in the hospital.
Really?
And nobody ever looked at it before. And I remember talking with people at the Gates Foundation several years ago about monitoring pulse rates in people over time. And they had an example where they were monitoring baseball pitchers, something I know is dear to your heart.
Yeah, very dear to my heart.
And they found that these guys were getting up to 200 beats per minute on the mound. And they were just amazed. How could this possibly be? Isn't that amazing? I think the more and more we're going to look at things where we look at them statically. You look at it today, you look at it a month from now, and in between it's going up and down like this, but it looks static. To you. There's a whole lot of fundamental work that needs to be done to know what it all means.
There is.
When you finally heard that it's all falling apart there, what did you think of all that? Had you anticipated it? Were you surprised by it?
Honestly, my response was it's a scam.
Mm-hmm.
My initial response and my final response was the whole thing's a scam.
Well, I had a lesson early on, way back in the 80s when I was at Chiron, and CETUS was in the same building as one of the labs where I was. And so I had this conversation one day with Kary Mullis, of course, the inventor of PCR. And he's describing to me how this is all going to work. And I said, Kary, that'll never work. And I thought I had a good reason for that. I thought the primers wouldn't stay on the same molecule and other practical things. But obviously, I was completely wrong. But I'll tell you that I learned a lesson then. It goes out and wins the Nobel Prize. And I'm thinking to myself nowadays, when I see new technologies, wait a minute, I'm thinking it's not going to work. Am I being like I was with Kary Mullis? And I need to look at this more deeply, right? So I was looking at this going, I looked at it every angle I could, and I just didn't get it. So I guess from my point of view, I was thinking either they're going to figure out that what they were trying to do is wrong, and they'll repurpose themselves and come up with something better and different, or like you say, it's just a perpetual scam, and it's going to fall apart one way or the other. Either change or die. It's one of the two options they had. It was a great dream. I think point of care testing, very convenient, low volumes. And I think that's created an awful lot of efforts by others to try and do this. It's happening, it'll never be able to do the half of molecule, right? We all know that. But being able to get to lower volumes of sample with better performing technologies that get you closer to a dream like that's happening. That's happening. And I think the good thing about what Elizabeth did was made people think about that dream. I know I've seen a lot of assays from a number of different laboratories that just don't have the clinical backing to verify that. But until many of these tests get through that regulatory process, you have to be a bit skeptical. You really have to be a bit skeptical. I mean, a lot of people believed in what Theranos was doing. Investors put a lot of money that was lost in it. She got to do some studies with Walgreens. She did some work there, but that backfired, especially when people started sending some of the same samples out to laboratories that were standard clear laboratories with, FDA approved products.
Different results.
Yeah, you get different results. You know that's a problem. It's going to be difficult for anyone who isn't a scientist to know that a lot of the hype is actually just that and doesn't have any basis in reality. Thanks so much for joining me today, Scott. I really appreciate it.
My pleasure. My pleasure.
Been great. You're a fantastic scientist and got a lot of great insight. Thanks for sharing a lot of that with us today. Thanks once again for joining us for another episode of Interesting Stories in the History of Diagnostics. This is Mickey Urday once again for Altaris Associates. See you next time.